I'm Dr. Colin Phipps. I'm a consultant in Haematology with Parkway Cancer Centre, and I'm based in Mount Elizabeth, Orchard, Singapore. So the recent advancements have been in diagnostics as well as treatment. Now this has grown in parallel because improved diagnostics has allowed us to classify blood cancers in a very detailed way by identifying exactly what type of cells are in the blood cancer itself. And there are so many types of blood cells that can become cancerous. It also has allowed us to look at the tumor very closely, such that we know what is driving the cancer's growth in terms of the surrounding cells that promote the blood cancer survival, as well as the genes and mutations that within the blood cancer that help it grow and survive despite treatments and despite our own immune defenses trying to kill the blood cancer. Now, because of this, we now know that what cells we are dealing with. We can design, and there have been a lot of progress in designing treatments that can specifically target these cells. The specific targeting means that we can now home in on the blood cancer cells that we want to kill, and the targeting also means that other cells in our body, a lot of our other cells in our body are spared, unlike the chemotherapy approach, which is basically to target all cells in our body that are growing very quickly, right? With chemotherapy, the problem has always been that not only is the targeting against the cancer cells, but other cells that grow quickly, like our hair follicles and our bone marrow cells, are also affected. And this is where targeted therapy has really changed things. So where patients were previously precluded from chemotherapy, for example, because they are not fit enough to withstand the toxicity, perhaps because they are elderly also, now these patients can receive effective treatments by way of these targeted therapies. So bone marrow transplantation, modern day bone marrow transplantation started in the late 1950s and 1960s. And this treatment then was considered experimental. The main role of bone marrow transplantation is basically, even then when it started, is basically to kill residual cancer cells, specifically for blood cancers that would be in the setting of acute leukemias. At that time, the bone marrow source was from a matched brother or sister, and the bone marrow source was directly from bone marrow. Over time, a few things happened that have improved outcomes in general. The first is the ability to match the patient and the donor very well, such that when the donor cells enter the patient's body, it doesn't cause too much problems, and on the other hand, the patient body does not reject the donor cells to a very high degree. That is one advancement. The second advancement is how we harvest stem cells from blood stem cells. As I said in the past, the only way used to be by directly taking it from the bone marrow, but now more than 97% of the time it is taken from the bloodstream. And most patients do not need to undergo, most donors do not need to undergo harvesting directly from the bone marrow. Now, another important advancement has been our ability to increase donor pool. Now, as I said in the past, it used to be only from siblings, so brother and sister. Now we can get the donor cells from a matched adult who is unrelated because of the proliferation of stem cell banks or registries around the world. If that is not successful in getting a donor, we have the option of cord blood cells, and that also has been in parallel with the proliferation of cord blood banks around the world. In Singapore, we have our own cord blood bank. And if still we cannot find a donor, our ability to transplant using a half-match donor, which is parents or children. So for lymphomas in particular, there's been a boom of the use of targeted therapy. That is in line with our knowledge about what type of lymphoma we are dealing with, what are the genes, and what are the survival pathways that promote the growth of these lymphomas. Today, there is about 60 plus subtypes of lymphoma, as opposed to 30 years ago, when we could only tell what type of lymphoma it was based on what we see under the microscope. Right? But now there are 60 plus because we know exactly how to look for the lymphoma cells, not only under the microscope, but using techniques like flow cytometry, like very advanced immunohistochemical staining, molecular techniques, and next generation sequencing. So stem cell transplantation is, for the patient, it is a journey. For us, it is an intense multidisciplinary approach. Starting from the time the patient arrives, from the time the patient arrives to find a donor for the patient, to match the patient with that donor, and then to work the patient up subsequently. Now, the multidisciplinary care starts before the transplant. The patient needs to be counseled with regards to infectious disease prevention of their own. It needs to be counseled for importance of adequate and clean nutrition. And of course, we need to tell the patient what to expect and what to expect, not only in what they will face during the transplant and period and after, but also in terms of what they can expect for their disease, whether you go to remission, whether you stay into remission, and so on. Now, for the transplant in the hospital, we have a transplant ward. Now, the transplant ward is very important because transplant patients are transplanted in positive pressure laminar flow rooms. And this means that all the time air is being pushed out from the room, so that there's no I would say dirty air that flows from the corridors into the patient's room. That is very, very important. And we have shown that that can actually reduce the rates of infection. The other thing about multidisciplinary approach is that our infectious disease protocols that we use were also crafted together with our infectious disease team. So immunotherapy is basically using the patient's own immune system to fight blood cancer, or using components of the immune system to fight the blood cancer. Now, over the years, it started with very, I would say, primitive medications, And then allogeneic stem cell transplantation is one of the oldest and most well-known forms of immunotherapy, where the donor cells that we inject into the patient are able to recognize the patient's cancer cells as foreign and have great potential to kill those cancer cells. Now that is the oldest and most time-tested form of immunotherapy in blood cancer. But medications now are equally important. We have what we call monoclonal antibodies that specifically recognize proteins on different blood cancer cells, can target them, and can kill them. Monoclonal antibodies are really, I would say, one of the mainstays of immunotherapy in blood cancers, especially in lymphoma. We also have checkpoint inhibitors. Now, checkpoint inhibitors basically are able to invigorate the patient's own immune system to try and kill the cancer cells. The other form of immunotherapy that is really up and coming in this region is chimeric antigen receptor T cell therapy, or CAR T cells, which are basically antibodies which are harvested from the patient and modified in the lab, modified in the laboratory, so that they can, when given back to the patient, they can recognize the blood cancer cell and effect very good killing of the cancer cells.